Welcome to healthU. Did you know that 1 in 4 men worldwide will experience prostatitis at some point in their lives, yet less than 10% of cases are actually caused by bacterial infection? Behind this seemingly contradictory statistic lies one of the most complex therapeutic challenges in modern urology. Today, we're diving deep into the treatment mysteries of bacterial prostatitis, revealing how antibiotics overcome one of the body's most difficult physiological barriers. Imagine the prostate as a fortress within the male body, protected by a special physiological barrier. When bacteria invade, not all antibiotics can cross this defensive line to reach the infection site. This is why prostatitis treatment is so challenging, and why many patients continue to relapse even after receiving treatment. Prostatitis is primarily divided into acute and chronic types. Acute prostatitis is like a sudden outbreak of war. Symptoms come fast and fierce. Patients experience fever, chills, pelvic pain, and severe urinary difficulties. This condition is usually easier to diagnose because symptoms are obvious and urine tests can quickly detect bacterial presence. Chronic prostatitis, however, is like prolonged guerrilla warfare. Symptoms fluctuate in severity and may persist for months or even years. Patients frequently experience lower abdominal discomfort, perineal pain, frequent urination, urgency, and sometimes sexual dysfunction. What's more troubling is that this chronic inflammatory state recurs repeatedly. Even when temporarily improved, it easily relapses. Among the causative bacteria in bacterial prostatitis, Escherichia coli, E. coli, is the primary culprit, accounting for 50% to 90% of cases. Next are Klebsiella and Enterococcus. These bacteria typically ascend from the urethra or reach prostatic tissue through blood circulation. Once they establish infection in the prostate, they become like enemy forces entrenched in a fortress, extremely difficult to eliminate. The traditional method for diagnosing prostatitis is quite unique, requiring prostatic massage. Physicians perform prostatic massage through rectal examination, then compare urine specimens collected before and after massage. If bacterial counts significantly increase in post-massage urine, chronic bacterial prostatitis can be diagnosed. While this process embarrasses many men, it remains the gold standard for diagnosis. Now let's discuss the core challenge of treatment: how antibiotics penetrate the prostate barrier. The prostate has a special blood-prostate barrier, similar to the brain's blood-brain barrier, which prevents most drugs from entering prostatic tissue. This barrier exists to protect the sperm production environment, but simultaneously makes treatment extremely difficult. Only antibiotics with specific characteristics can effectively cross this barrier. First, high lipid solubility is essential, as lipophilic drugs more easily penetrate cell membranes. Second, low protein binding is crucial, because only unbound free drug molecules can exert therapeutic effects. Third, low ionization degree is important, as neutral molecules cross physiological barriers more easily than charged ions. Finally, small molecular size matters, as smaller drug molecules diffuse more readily into deep tissues. Fluoroquinolone antibiotics have become the first-line treatment for prostatitis precisely because they possess these ideal pharmacological properties. This class includes ciprofloxacin, levofloxacin, moxifloxacin, and others. They not only have broad antimicrobial spectra, but, more importantly, excellent tissue penetration capabilities. Let's examine the penetration mechanisms of fluoroquinolone antibiotics in detail. First is the ion trapping effect. When prostate infection occurs, tissue pH changes from a normally weakly acidic environment to weakly alkaline, reaching pH 8.34. Fluoroquinolone antibiotics become ionized in this alkaline environment, forming charged molecular forms. These charged molecules cannot easily diffuse out of tissues like being trapped. They actually concentrate in infected tissues, achieving higher concentrations than in blood. Besides passive diffusion, active transport mechanisms exist in prostatic tissue. Some carrier proteins actively transport fluoroquinolone antibiotics into prostate cells. Simultaneously, efflux pumps exist that expel drugs outward. These two opposing mechanisms create dynamic equilibrium that ultimately determines drug concentrations in prostatic tissue. According to the latest pharmacokinetic research, moxifloxacin demonstrates superior distribution in prostatic tissue compared to levofloxacin. Moxifloxacin's tissue-to-plasma concentration ratio can reach 1.24, which is 59% higher than levofloxacin. This means moxifloxacin achieves higher therapeutic concentrations in prostatic tissue with better bacterial killing effects. Some fluoroquinolone antibiotics achieve prostate tissue to serum concentration ratios of up to 4:1, meaning prostatic tissue drug concentrations are 4 times higher than blood levels. This high concentration drug distribution is a key factor for successful prostatitis treatment. In actual clinical treatment, acute prostatitis typically requires 14 to 30 days of antibiotic therapy. Initial treatment may require intravenous administration to ensure rapid achievement of effective blood drug concentrations. Once symptoms improve, oral administration can complete the entire course. Chronic prostatitis treatment is more difficult, requiring 4 to 6 weeks of extended therapy. This is because chronic infections usually involve biofilm formation. Bacteria secrete polysaccharide substances forming protective films, like wearing armor, making antibiotics less effective. Long-term antibiotic treatment helps gradually destroy these biofilms, thoroughly eliminating hidden bacteria. Regarding drug selection, besides fluoroquinolone antibiotics, trimethoprim sulfamethoxazole, TMP-SMX, is also a commonly used first-line medication. Composed of sulfamethoxazole and trimethoprim, it has good antibacterial effects against gram-negative bacteria and lower cost. However, its tissue penetration ability is inferior to fluoroquinolone antibiotics. Recently, oral fosfomycin has become a noteworthy new option. Fosfomycin is an old antibiotic that has regained attention due to its unique mechanism of action and good tissue penetration. Research shows that a treatment regimen of 3 grams daily for 1 week, then 3 grams every 2 days for 6 to 12 weeks, shows good efficacy for chronic prostatitis. Despite these treatment options, prostatitis cure rates remain less than ideal. Chronic bacterial prostatitis cure rates range from approximately 33% to 71%. This relatively low success rate reflects the complexity and challenges of treating prostatic infections. Many factors influence treatment success rates. First is bacterial antibiotic resistance. With widespread antibiotic use, increasing numbers of bacteria have developed resistance to commonly used antibiotics. Second is patient compliance. Long-term antibiotic treatment easily leads to patient abandonment. Third are individual differences. Different patients have varying drug metabolism capabilities and tissue penetration. Approximately 5 to 10% of acute prostatitis patients progress to chronic prostatitis. Research has found that cystostomy during the acute phase and prolonged antibiotic treatment can reduce the risk of chronicity. This reminds us that initial treatment of acute prostatitis is crucial. Complete infection clearance must be ensured. Culture-guided therapy is an important principle in modern prostatitis management. Before starting antibiotic treatment, urine or prostatic fluid should be collected for bacterial culture and antibiotic sensitivity testing. Selecting the most effective antibiotics based on culture results can greatly improve treatment success rates while reducing antibiotic resistance development. Besides antibiotic treatment, lifestyle adjustments are also important. Patients should drink plenty of water to help flush bacteria from the urinary tract. Regular exercise can improve pelvic floor muscle blood circulation. Avoid prolonged sitting, especially activities that compress the perineum like cycling. Quit smoking and excessive alcohol consumption, as these habits affect immune system function. Regarding diet, spicy food intake should be reduced as these foods may irritate the urethra and prostate. Increasing foods rich in antioxidants, such as lycopene in tomatoes, may benefit prostate health. For patients with recurrent episodes, prophylactic antibiotic treatment may need consideration. Low-dose long-term antibiotic use can prevent bacterial reinfection. However, this strategy must be conducted under close physician supervision to prevent antibiotic resistance development. Future prostatitis treatment will move toward more personalized approaches. Genetic testing can help predict patient responses to different antibiotics, selecting the most suitable treatment regimens. Advances in pharmacogenomics allow us to adjust drug dosages based on patient genotypes, achieving optimal therapeutic effects. New delivery methods are also under development. Direct intraprostatic antibiotic injection can bypass the blood-prostate barrier, directly achieving high concentrations at infection sites. Although this method is more invasive, it may be an effective option for refractory infections. Nanoparticle drug delivery technology also brings new hope for prostatitis treatment. Through specially designed nanoparticles, antibiotics can be more effectively transported to prostatic tissue while reducing systemic side effects. Immunomodulatory therapy is also a future research direction. Prostatitis involves not only bacterial infection but also excessive immune system reactions. By modulating immune responses, we may better control inflammatory states and reduce symptom recurrence. Combination therapy with antibiotics and plant extracts also shows potential. Certain plant components have anti-inflammatory and antimicrobial effects that may produce synergistic effects when combined with traditional antibiotics. Prevention remains the best strategy. Maintaining good personal hygiene habits, promptly treating urinary tract infections, and avoiding unsafe sexual practices all help prevent prostatitis occurrence. Regular urological examinations, especially for men with risk factors, can enable early detection and treatment of prostate problems. Although bacterial prostatitis treatment is challenging, our understanding of this disease deepens with medical science advances. From molecular-level understanding of antibiotic penetration mechanisms to clinical applications of personalized medicine, each advancement brings new hope for patients. Most importantly, patients must have patience and confidence. Prostatitis treatment often requires extended time, and symptom improvement may be gradual. Close cooperation with physicians, timely medication compliance, and regular follow-ups are keys to treatment success. Meanwhile, maintaining healthy lifestyles, appropriate exercise, and balanced diets all contribute to physical recovery. Through today's in-depth analysis, we've understood the complex mechanisms and latest advances in bacterial prostatitis treatment. This seemingly simple urinary tract infection actually involves complex pathophysiological processes and treatment strategies. With the arrival of the precision medicine era, we believe more breakthrough treatments will emerge, bringing better therapeutic outcomes and quality of life for men suffering from this condition.